So we will now shift gears a little bit, and we're going to actually have a debate. And we're going to debate on CTOs. So Paul, who's an amazing interventional cardiologist, chief of cardiology at Scripps Clinic, but more than anything else, the interventional cardiologist to Mother Teresa when she was alive, is going to make the point that CTO interventions are underused. And then Rasha Al Lamee, who's a consultant at the Imperial College and the principal investigator of Orbita trials, she's fierce and she's fearless. She is going to make the argument that CTO interventions are overused and have questionable clinical value. So, Paul?
Well, thank you. It's always fun to be here, and just great topics, great interaction, and wonderful people. So I'm going to get right to it. I was given this task of presenting CTO interventions as being underutilized. First I'll start. Rasha and I have been doing this now for almost a decade. And this I got the first time I debated her. It was at OPCI. And she had just come out with Orbita. And I believe I got this off Facebook. This was your 40th birthday, I think. Yeah. And you were teaching Daryl Francis how to dance, and he wasn't learning. And now look what's happened in 10 years here. Rasha now is a full professor. She's famous. She's all grown up. She's now officiating her medical school graduation. And all of it is because she keeps beating me in all of these debates. That's your success, Rasha. Okay, so when I received this assignment, I immediately said yes, because first of all, debating Rasha is always so much fun. And I have strong opinions about CTO, PCI. I knew exactly what I wanted to say. But I knew I'd have to back up my opinions with data. And pulling together data for these talks, I mean, Greg can tell you, it's a pain in the neck. It's a lot of work, a lot of hours. So I did two things. First, I phoned a friend, Kate Kearney. I contacted Kate up in UW and said, please send me some of your CTO slides. And the other thing I did was I was sitting at Starbucks, and I pulled out my phone, and I got out ChatGPT, and I gave it the following prompt while I'm sipping my latte. Compare the speaking style of Rasha Al Lamee to Paul Teirstein. Okay. Now, this shocked me. And this, Rasha, you're going to die when you hear this. I waited 10 seconds. Now, I don't know what it does in this 10 seconds. But presumably, it listened to everything you ever said on the Internet. TCT talks. I don't know if this is going to be on the Internet. PCR. 10 seconds, and this is what it said. She's data-driven, meticulous, analytic. Tone is measured, calm, incisive, rather than aggressive. Points out logical gaps, cognitive biases. We think we know, but we don't. And on and on and on. And I was just shocked. Your core vibe, you know what ChatGPT says? Elegant skeptic with sharp reasoning and a command of trial methodology. Now, most of us know Rasha. That's Rasha, right? I mean, this thing knows you better than your husband knows you. I mean, it's insane. And 10 seconds. I do have some idea now where all these data centers are being built around the country, because this is crazy. Sorry. Next thing I did was, okay, what about me? Right now, I just have to warn you. I have to warn you that this device, ChatGPT, doesn't say bad things about anybody, okay, because it wants you to come back. Okay, so this is what it says about me. Charismatic, fast-paced, confident, humorous, speaks with procedural authority and clinical experience, comfortable making bold statements. I am loving ChatGPT, right? Who doesn't like this, all right? My core valve, a master proceduralist with high energy advocacy, and we fix problems, pragmatism. I gotta say, I don't know if that's my speaking style, but if someone asked me to describe myself, I wouldn't even know how to do it. But this is what I was looking for. This thing knows. I was shocked. So now I'm sitting there at Starbucks, and first, then it gives me a nice contrast. So you see your tone, calm, precise. I'm energetic and bold. All right. So then I ask, all right, I got this problem. I got to debate Rasha in this debate. Well, I'm taking the calm position. What points will she make? What's she going to say? So this takes about. It goes right back and says, okay, I can help you craft your pro-CTO argument based on specifically against her style. Anticipated counter-arguments. I was just dying here. And a point-by-point rebuttal. So this is what I wrote back. By this time, this thing is my best friend, right? So I wrote back, hey, this is very helpful. I wanted to give it a pat on the back, encourage it. Okay. I'm, I'm seeing this on my iPhone. I want to turn this analysis into a PowerPoint. What's the most efficient way of doing this? So it comes back right away. It says, oh, here's the fastest, easiest way to do it. Made me select. You said to select the first one. It said basically, just ask me to create a PowerPoint. So that's what I did. Actually, I clicked one. That's all I had to do. And then it was 15 seconds. This was a little longer. And then all of a sudden, pop. Here's your PowerPoint ready to download. And I said, I just was in shock. Okay, so here's the points that Rasha's going to make. Now, I don't want to steal Rasha's thunder, but I want to go over them quickly just to see, because your slides are in there. We're going to find out whether it got it right or not. All right? So it says, it was very specific. You're going to focus on 4 major domains, okay? First, evidence for symptomatic benefit is limited and inconsistent. She will emphasize orbiter and sham-controlled lesions, even though orbiter wasn't CTO specific. She frequently cites it to illustrate observed symptom benefit from PCI can be due to placebo. All right, we should not assume PCI improves symptoms without robust evidence. And then she may list the typical trials. These are the randomized trials are listed here. She may list those. Her position, the randomized data do not show a compelling advantage for routine PCI and CTOs. I think they're right about that. She will increase procedural risk is another point you're going to make. She'll highlight CTO PCI as longer, higher radiation, more contrast, riskier perforation, donor vessel injury. It knows about donor vessel injury. I mean, it's amazing. AKI. She will contrast this with its marginal clinical benefits. Her line, I like the way it does this, like her line, her angle. We expose patients to substantially greater risk for outcomes that are often subjective and inconsistently improved. All right, that's the second point. Third point you're going to make is that it should be highly restrictive. It's only for patients with severe lifestyle limiting symptoms after optimal medical therapy. She'll stress the importance of objective ischemia and symptom correlations, shared decision-making. PCI is not for symptomatic patients, for asymptomatic patients, or just to get the artery open. She often critiques anatomy-driven enthusiasm. Her tone, wait for it, just because we can doesn't mean we should. I don't know how it knows this in 15 seconds. And then your final point is going to be the importance of humility in interpreting subjective outcomes, i.e. PCI for stable coronary disease does not save lives. You guys are not saving lives. She will likely return to her signature theme. Symptoms are variable. Perceptions can be influenced. Blinding matters for her recurring refrain. We overestimate the benefit of revascularization because we cannot blind ourselves. She often says things like, we must separate biology from psychology. It's got your number. All right. Okay. Now me. So I'm taking the pro piece. What should I say? 15 seconds later. Okay. Below is a fully crafted pro CTO debate, followed by a point-by-point rebuttal to Rasha's arguments. All right. Here it is. Okay. The rebuttal of randomized trials show little or no benefit. Now I have to criticize the trials, of course. Decision CTO was limited by crossovers and weak enrollment. Trials enrolling symptomatic patients like Euro CTO, Common CTO show real QOL benefits, quality of life benefits. Your take should be symptoms are legitimate outcomes. Patients want relief. Okay. What about her argument that the PCI benefits may be just placebo? Well, I'm supposed to say Orbiter was not a CTO study. CTO physiology is entirely different. There's a large ischemic burden. There's collateral dependence. And I guess it doesn't know you're working on Orbiter CTO. It didn't get that one yet. And then impactor CPO, I thought that was a good one. They found improved stress ischemia correlated with improved symptom relief. And I think it's true, but it was a very small trial. My angle, physiologic improvements are not placebo. That's not bad. Now, what about your procedural risk argument? I'm supposed to say modern CTO PCI is far safer than legacy data suggests. Don't be fooled, Rasha, by outdated perceptions. Modern CTO PCI techniques drastically reduce complications. The hybrid algorithm improves efficiency, risk-benefit, overwhelmingly favorable in properly selected patients. Expert centers consistently deliver greater than 90% success rate with low event rates. Now, at this point, as a moderator myself, I have to step in and say, I think this is an AI hallucination. Okay, it's 90% is not the right thing to sell you to patients. The way I do this is I tell them, look, if your artery was 99% narrowed, I'd have an almost 99% chance of success. But since it's 100% narrowed, my chance of success is, and I pick a number between 30 and 80, depending on the lesion, its length, its viscosity, the ambiguity of the proximal cap, etc. So I think this one is definitely wrong. And what about selective use argument? Well, I'm supposed to argue, yeah, I should agree. It is selective, but I disagree on Rasha's position of extreme restriction. Right? Symptoms are the foundation of stable ischemic heart disease. Symptom improvements are matched by perfusion improvements. Objective ischemia reduction validates symptom relief. My tagline is, patients seek symptom relief, not statistical endpoints. That's not bad. That's not bad. That's a pretty good one. All right, and his final close, CTO is not about opening arteries. It's about restoring perfusion, reducing ischemia, relieving symptoms, and improving quality of life. When performed by experts and appropriately selected patients, it is a safe, effective, and transformative. It's not bad, all right? And I'll just quickly show the data, the slides I got from Kate and others. Decision CTO really didn't show anything. There's 1,000 patients randomized. Euro CTO did have benefits in quality of life, but MACE was mostly revascularization, so that's a soft endpoint, and it wasn't blinded. And then this is the excuse slide that comes with that. You know, a lot of crossovers, slow enrollment, not blinded, yada, yada, yada. Open CTO register was 1,000 consecutive patients, which is not bad. These were in high-end sites with an 86% success rate, and so that is showing a lot of progress. But look at the perforation rate. That's nothing to write home about, a 5% perforation rate. Impact or CTO was a very small randomized trial, about 100 patients randomized. In that trial, the improvements in myocardial ischemic burden did correlate with quality of life improvements. So that did show physiology and symptoms connected. And Rasha just recently published this analysis of Overused, which she found the same thing with W-mean stress tests and quality of life. So I'm going to just finish with something personal and sort of emotional that I think relates to this. I'm going to show you a confidential letter, handwritten, 5-page letter that I received in June of 1988 from my boss, the chief of cardiology at Scripps. And what happened was, I walked into his office and I asked him for a really big raise. I told him that I thought I should be a senior economic division member. I was hired as a half member, and it was like a 5-year climb to seniority. And I told him I should be a senior member now. And he said, Paul, you've only been here for 6 months. And I said, yeah, but I'm working late, and we're moving this program along. And he said, well, I'll talk about it with the other senior partners. 2 days later, I received this 5-page handwritten, he didn't even want his secretary to see it, handwritten letter about how terrible I was, what a terrible person I was. And I keep it in my desk, and I use it to show the other young doctors who get in trouble, and it helps me. So here's my favorite paragraph from it. The almost, if not absolutely universal impression of your administrative and communicative skills, techniques, methods is that you have miles to go. You are generally abrasive, parochially focused, perceived as petulant and immature. On any given day, I receive complaints about how you have interacted with someone or commonly various groups of people. It is not uncommon for the entire cath lab crew, the OR crew, CV surgeons and their support staff, radiologists, etc., all to be in high dudgeon because of your actions. This guy can write. He can really write, okay? You are described as a loose cannon on a rolling gun deck. But then 5 pages into this, so I'm shocked, okay? So I thought I was such a nice guy. And people always said good things about me. So the last paragraph, though, was really gripped me. And it said, it's paragraph 5. We are encouraged. We are concerned about your motivations. You and I know that you can get a high from succeeding with a difficult case. At times we perceive that, quote, pulling one off can take precedence over the overall interests of what might be the wisest, safest course for the patient. And that's really stunned me because I was worried about the same thing. I've been at Scripps for 6 months. In the 80s, we were pushing this field forward, and a lot of people in the room were there with us. And I was worried about protecting the patient. That's something there's a little bit of an art to pushing the field forward and still protecting the patient. I was really learning that. And I even wrote in the margin there, I wrote true and very insightful. And I think it's really relates to this topic about doing CTOs where maybe it's not going to benefit the patient as much as you might harm the patient and that kind of thing. So I keep it there. I was also able to use this paragraph to go back to his office and thank him for his constructive criticism. And then I said, let's get back to talking about my raise. All right, so my final slide, what I, not AI, really believe. First of all, I love ChatGPT. I have fallen in love with ChatGPT. I really get it now. I think over the last 20 years, the hybrid algorithm and other advanced CTO techniques have pushed all of PCI forward, but 100% occlusions are stable. I tell patients, your 100% occlusion can't become 110 occluded. If you don't open your CTO, your collaterals will be there forever. Advanced CTO techniques do have increased risks. Be sure your patient knows this. Make sure you're offering the patient significant benefit. Be sure you're trying to help real symptoms. And Rasha, I'm sure, will next talk a little bit about what real symptoms are and how to distinguish them from atypical symptoms. Go over the risk-benefit equation with complete honesty. In the end, what I tell patients is this. I say, hey, this is a gray area with lots of pros and cons. But if you were a family member, this is what I would recommend. And then you tell them what you'd recommend. Thank you for your attention.
All right, Rasha. Let's see if Claude.
Now I don't know what to say because I think ChatGPT basically is going to predict the entirety of my talk. And I've often thought that debates would be best debated if we had exactly the same slide deck. So that next year, that's what we're doing, Paul. We will have exactly the same slide deck and give our opinions to exactly the same slide deck. Here are my disclosures. So my first disclosure that isn't on this slide is something that ChatGPT didn't say when it described me. It didn't say that every time I'm asked to debate, usually in the US, actually what people think of me is the harbinger of doom. I am always the person who's here to tell everyone what they should or shouldn't do, tell them what they should be considering in the lab, try and keep the party out of the room. But also what ChatGPT didn't say is that Paul and I are friends. So everything I go on to say in this talk comes within the spirit that we are friends, and that we usually come to the same point in our debates. So now I'm a bit worried because now ChatGPT is going to predict everything that I say. So let's talk about CTO PCI. So what do the guidelines say? Well, they say it's a 2B indication. That actually the benefit of PCI for CTO to improve symptoms is uncertain. And really, I think the guidelines got that right. We know that there are some patients in which this might help. And what's interesting when you go back and look at all of the CTO kind of reviews out there is in tables like this, when they talk about the indications and the techniques of CTO, they always give only one indication to improve symptoms. Most people now understand that that's the main place of this. But of course, you can't make a table out of one particular indication. So then they go on to talk about how we do it. And we end up spending most of the review talking about the tips and tricks of trying to open an artery that's been closed for 100 years. And unfortunately, that's, I think, one of the major problems around CTO PCI. We forget that this is about why we do it. We spend the whole time saying how we should do it. And that's what most of our CTO courses are about. Many of the CTO operators focus only on those next 6 points. So how did we ever get here to a point where we spend endless hours poking into a space, not understanding exactly what we're doing, trying to pretend that this is incredibly precise, when actually most of the time it's not? We got here because we decided at some point that having a CTO had a poor prognostic value for our patients. But of course, for most of those patients with CTOs, we know that they have lots and lots of other comorbidities that make them more likely to have bad outcomes over time. And I feel myself, as I'm giving this talk, feeling that ChatGPT predicted exactly how I might speak, and I've never had that before. But let's talk about the history of CTO. So unfortunately, the history of the CTOs and the first CTO starts ages ago, in 1978. In fact, the year I was born. And it takes decades, absolutely decades, of people talking about different ways that they can do it, bringing out little tools, deciding on different ways they can do it, before we finally start to have some trial data. That is maddening to me. It's incredible that an industry is built up for decades before we start to actually look for something beyond observational data to decide whether we should be doing what we're doing. And if we go back to some of that observational data, the very early observational data said that CTO-PCI saved lives. But of course, they were comparing unsuccessful versus successful CTO-PCI in patients that have all sorts of confounding factors for why you might be able to open up a vessel or why you might not. And more recently, we've got more data, albeit within a randomized controlled trial, but essentially in an observational setting, that shows us that potentially doing this might have some prognostic value. And I would argue that's actually not been borne out by any of the randomized controlled trials. Decision CTO, we've already talked about it. ChatGPT told us that I was going to say that in this trial there were lots of limitations. Of course, there was lots of early crossover. The trial was very hard to do. We know that the trial was stopped early, and fundamentally they showed no difference in MACE for patients who had CTO-PCI. Symptoms didn't improve in this unblinded trial, and we know that, of course, in unblinded trials there's a potential placebo effect to the procedure itself. And then, of course, we have EuroCTO, in which they told us that symptoms really improved in their patients. But in fact, what they saw was symptom improvement in both the control arm and the PCI arm, and we can see this in all of the data sets. And importantly, while they may have seen some improvements in physical limitation and angina frequency, we don't know how much of that improvement was the true physical effect. And we can see that on things like CCS class, when a physician or a healthcare provider judges the angina grade of their patients, they judged that the control arm patients improved a little, and perhaps the PCI arm patients improved a little more. But what we also know is that when we assess the angina grade of our patients in an unblinded trial, we are much more likely to overemphasize the improvement that our patients might have gotten. I've spent 5 hours doing a procedure. Of course, I'm going to say that their angina is a little bit better than the patient in which I did nothing. And of course, it's not, the lines are very blurred between what's CCS class 3 and what's CCS class 2. And we're more likely, as the healthcare providers, to judge a benefit in the patients that we think we might have done some good in. We also know that there is a placebo effect to that CTO procedure, because even when we fail at successfully opening up a CTO, we can see symptom improvement in our trials. So even when we tell a patient we spent hours trying to open up that occluded artery, we haven't successfully done it, they feel a little better. There must be something around the psychology of having that very long procedure with that incredibly expert operator trying to open up their artery that just makes them feel better because you cared for them for many, many hours that day. And of course, what we have also out there in the literature is lots and lots of single-arm, observational, uncontrolled data trying to tell us that CTO-PCI improves symptoms. Despite all of the limitations of data, what we also have is 1 million algorithms telling us all the various ways you might go antegrade or retrograde, you might switch from one to the other. Paul has told us all about the various hybrid algorithms, because in fact, every review article you might read on CTO will have a small paragraph about the indications, and they will move very rapidly to this bit, the fun bit. How am I going to open it up? What am I going to do? How much kit will I use? They are extremely excited when the table behind them is stacked so high people have to clear it and there's kit everywhere and no one's got enough space. And importantly, what we also know is that not everyone does CTO-PCI for the right indications, and probably when we look at the registry data, it's actually better than the reality. And we all know in our own centres people who are committing people to procedures for hours on end for a bit of breathlessness, that may be because they're overweight or maybe because of their respiratory disease. And we know that that's probably wrong. So, what did ChatGPT not predict? Well, it's the next few slides. Because I think there are other indications for CTO PCI, and in fact, Paul alluded to some of those in his final letter from his boss. Let's think about the kit, the gladius, the crossboss, the samurai, the fighter, the guidezilla, the stingray, the wolverine, and even worse, the conquest. Just look at the language of the kit that these boys and girls use. And you tell me that they're doing this for the patient benefit. The patient is at the center of everything I do. That's exactly why you're doing it, Paul. And more importantly, and it gets worse, and at this point I'm not going to read them out, let's think about the terminology and the techniques. And again, and again, and again, the power knuckle. And let's think about the slash technique, which they use with subintimal lasso into the subintimal space. And then my favorite, grenadoplasty. So have a look at those terms up there. And as I put those down on a slide, I was doing it because I'd wandered around enough conferences, sat on enough live cases, WhatsApped my various fellows a million times with the horrendous terminology that I heard people use. And I thought at some point I need to do an expose. This stuff's not right. We don't see this terminology in a heart failure clinic or in a prevention clinic. Our TAVI and mitral operators don't use these kind of words. And there must be a better way to describe these techniques, and there must be a psychology to the people that think it's okay to use these techniques. So the other thing I'd like you to do is next time you, Paul, perform or watch a CTO case, I'd like to ask yourself, is it actually all about the conquest? Is there something else that drags you into a lab for 5 hours on end, and at the end of an unsuccessful procedure says it was an investment? It was a really, really good time. I really enjoyed it, and hopefully you might feel a bit better. And finally, what I also hate to hear the CTO operators say is, the reason I do it is because it makes me so much better at regular PCI. And it's really improved how I manage complications. You hear this all the time in the live cases. And today I'm going to ask you, is that what they tell their patients when they consent them for the procedure? The reason we're doing this today is because I just get better at other people's PCI. I need to spend 5 hours on you so that next week, if I have a complication, I know how to fix it. I would like that to be on their consent forms. So is all that fun and all that conquest really worth the harm? I don't think so. Let's look at some of the in-hospital complication rates, and here ChatGPT stole my thunder. We have complication rates that are incredibly high. It's not normal to see perforation rates of 8.8%, and these are in registries. It may be even worse in real life. That's not what we expect. How often do we see perforations with standard PCI? It's the same in the US as it is in Europe, and we know that there's mortality rates. We also know that there are peri-procedural MI rates, and those peri-procedural MI rates are not benign. And in some patients, they are associated with increased MACE. And importantly, these investment procedures that people invest in are not investment procedures. They cost our healthcare systems lots of money. They have complications associated with them. And interestingly, they clearly have a placebo component, because many of those patients start to feel a bit better because they've been spent 5 hours in the lab with someone piling up the kit behind them as they try and open up that blocked artery. So I will now move you very quickly to a trial that you will see presented at ACC. And that's the first placebo-controlled trial of PCI in CTO. And what myself and my team, but also most importantly what was led by the team at the Essex Cardiothoracic Centre, have sought to do is try and work out whether this procedure really offers symptom benefit. It's a placebo-controlled trial and it's multi-centre. The inclusion criteria you can see here, but it basically is really focused on taking patients with lots of symptoms, with a relatively straightforward CTO, and clinical evidence of ischemia. There are multiple exclusion criteria, and the primary endpoint is a change in angina frequency on a symptom app, the Orbiter app. And importantly, there is also a big component that's around the blinding, because of course blinding this trial was tricky. It involved making sure there were no clocks in the room, that patients were entirely sedated, that they had double access, both in the placebo arm and of course in the treatment arm, and we'll see the results. There are some key secondary outcomes that you'll see, and it'll be presented at ACC 2026, hopefully with a simultaneous publication, and I'm sure there'll be lots of dissection of the results. So in my view, given everything I've said about the risks and costs of this procedure, I will only be prepared to think about CTO PCI once we have placebo-controlled evidence that it works, and I'm prepared to throw it in the bin if it doesn't work. And only then am I prepared to read lots of reviews about how you do it and what you do it and the hybrid algorithms and all the rest when someone proves to me that it works. So, Paul, I'd like to talk about your path to becoming a CTO operator. So the reviews would say you have to have a strong clinical need in your local area. You should have an inspiring mentor or role model. I hope you found another one, one that didn't write you a 5-page letter. And a psychological profile that thrives with challenge and is comfortable with procedural complexity. And, you know, I wrote this myself. I didn't get ChatGPT. You also need humility, self-reflection, and I think you need to know when to start and when to stop. And interestingly, again, in the CTO literature, you will find editorials about the path to being a CTO operator and the psychology of being one of these big guns. And of course, they talk about ignorance peaks, desperation alley, and the master plateau. And I think you're there, Paul, at the master plateau, flying one of your lovely aluminium planes. And importantly, I do think that CTO interventions are overused and have questionable value. I think, given that there is a total lack of robust data and lots of associated risks, the growth in this field is mad to me. In fact, I think there's a panorama expose in it. I think the enthusiasm in the field is influenced by factors that are not patient-centered, and we cannot pretend that it's all about putting the patient in the front of the operator's mind. Placebo-controlled data is coming, and of course, if it's positive, we can all cheer. But whatever the data show, patient selection has to be key to making decisions before we take patients in, and we need to know when to stop and decide that the harm is really outweighing the benefit. And I'll stop there, and I'm sorry if ChatGPT predicted most of the things that I would say.